Yeah, and also minor, I think, two little things. I have
All right.
um, a patient that describes has pain or tenderness along, kind of all along the occiput, basically,
Okay.
you know, from kind of center all the way out.
Mhm.
And she describes, you know, when she moves her head, she describes like there's a kind of a cracking and clicking,
Mhm.
clicking sound. Um, I don't know, is it just the normal things you might treat, you know, third toe and Sanjiao 8 and that kind of thing for the
Yeah.
occiput?
So,
Or
I
are
mean,
you doing it?
oh, okay.
Would
So,
it be a
well,
tendon? I was just thinking, would it be, sorry, kind of like a tendon? You know, this, she described it as a kind of a clicking and cracking kind of
the
sound.
clicking and cracking is hard to know exactly where it comes from. I mean, no, I mean, as far as I know, there's no clarity around where it is. It can be, yes, it can be a tendon. I think that's what you were asking, but it can also be a muscle that's tight and jumps over something else. It can be a bone. No one really knows, you know, as far as I can tell. No one can have a definitive what these cracking noises are exactly are. It's, you know, the theory is that it's supposed to be some sort of air bubbles that are bursting or something between the joints or something, and you've got plenty of joints going on. So you can't tell which, it could come from a cervical. And the thing is, because your ears are there, you can't tell where that cracking noise is really, you know, it could come from all the way in the thoracics. And it can feel like it's coming, you know, from your inside your head. So I think it's hard to know where they're coming from, you know, both mechanically speaking. I don't think that there's a satisfactory explanation. There may be, but my understanding is that that it's a guess of what we think those cracking noises are. But what I would do is, so of course, the first thing is, what else is the patient having constitutionally? What's the medical history? Because, and that might lead you to, oh yeah, you know, occipital pain, since it's both sides, by the way. So you have, here are your three options, you know, the dogmatic little options that you can have. Yes, it can be a blood pressure or an autonomic nervous system disorder, which shows on the occiput. Okay.
Yeah.
It could be a hormonal, but you're saying it shows the whole way, not just more to the side. So it's a little less likely to be hormonal. And I did have a third one, and it escaped me. I guess Alzheimer's does its toll. Oh, there is what we call it can be a mechanical basilar artery insufficiency, you know, syndrome, so thing, which is basically you know, a narrowing of all the joints there. So those are the three kind of like obvious, you know, syndromes that a person supposedly can fall onto. And the other one is, if it was right-sided only, it could be a liver sort of thing, an extension of Oketsu or of liver. So those are your, if you are just addressing that. Now, so you want to address the history, obviously, and then in terms of mechanics, yeah, Sanjiao 8 is generally a very good point for these things. For the it's not as good for the occiput as it is for the cervicals. So the occiput, it's not the best point for that. Um, Usually small intestine 3, whether it's hormonal or not, tends to be a little bit better for the occiput. Under the third toe is better for the occiput. Inner yin can do a good job for this. If it is the so-called basilar artery insufficiency or something similar, you know, there's still the mechanics of the neck. I do look for kidney. Either the original combination was kidney 10, liver 8, and Sanjiao 8. That's basilar artery insufficiency. I tend to find that instead of liver 8, often I will use inner yin. And kidney 10, I very rarely use in this case. I usually use either kidney 7 or kidney 9. They tend to be much better points for the neck, in my experience, than kidney 10. And on the back, it's Ihikon, and it's, you know, at some point, I remember I even did a little drawing, you know, this whole area of the gastrocnemius, especially slightly lateral from the center line, is very good for neck, regardless of which point it actually is. And that's true across styles. You know, for example, the tongue people like using what they call correct tendons, which is on the Achilles tendon, level with kidney 3 and kidney 7. So that's kind of like the, and then you can always look at REN 12 or REN 13, which is a good point for spine. If you think it's more spine, you should always check the scalenes, the brachial plexus, because the neck is supplied through that. So, you know, and that point you're looking at possibly releasing this with spleen 3, lung 8, inner yin, heart 3. So, and then another point that's really good for occiput is either UB2, or you can go all the way from UB2 to gallbladder 14. Okay, you know, there's just a fascial line that connects the occiput and the eye. Gallbladder 1, for example, doesn't do it. So it doesn't go as wide, you know, that fascial plane is really more like, you know, I don't know if it involves the center line or not, but it definitely involves the from UB2 to in the center is Yu Yao, I suppose, and you know, and so you can pick it up even at gallbladder 14, which is above Yu Yao. Another point that often does do a good job, so it does actually pick up at the center. As a matter of fact, is DO24 is a good point for occipital pain often. And then anything to do with neck, I still check on the back. So often, especially if they're lying down and they, you know, at that point, if their head is in a headrest, they can't really turn the head and say it's cracking or not cracking. But what they can do is they can lift their head up. Okay? And some people definitely can tell that there is a problem. Sacroiliac ligaments are generally good for that. And then, well, of course, I do the whole spine because, you know, I want to get T11, T12, and T5 regardless because they're, you know, the big curves in the back, so they're going to influence the rest of the curve, but especially T5 and above. So T5 to T3, T3 is the pillar of the body, Genju, which is supposed to be very good for neck. So those are the, then if you're really not getting anything, I would look at the stomach 9 area. Stomach 9, large intestine 18, a little above, a little below. I would look at that. I do a very, you know, like, you know, Hafts needle, like 15 millimeter needle and very narrow, very thin needle. There are people in China that use 2-inch needles here. It's the same idea as like, you know, the people, you know, they used to do back neck surgeries from the back.
Is that
They now
Miriam
do them
Lee?
from, sorry?
Is that Miriam Lee?
Yeah, well, it wasn't actually Miriam Lee. I haven't seen her do that. But her style kind of people. I remember I started using this area because this woman, Jiang Fujiang, recommended, you know, needling large intestine 18 for neck pain. Very, very effective. And yes, it's true, but, you know, it's like, you know, the idea is that you can basically scrape the vertebrae from the front, just like they do the surgeries from the front now. But honestly, with a tiny needle, it's possible that a longer needle is more effective because you're getting there more directly. With a teeny needle, it's the vibration that eventually gets to the area, fine. But it feels a lot safer. I mean, honestly, 30 years ago, I was needling people here with a 2-inch needle. But I wouldn't dare do it nowadays. You know, you grow a little older and you get more cautious.
I get a bit scared of that, the artery. I'm going to hit
I'm not so scared of the artery. I'm scared about what's happening behind the artery. I mean, because the artery, you can tell that you're avoiding. It's everything that's, you know, like, do you really want to needle into someone's trachea, etc. I mean, it's just not my cup of tea. So, you know, just like, you know, I used to needle bladder 1, you know, and I used to, you know, when patients would get scared of it, I'll do it on myself, you know, in front of them to show them no big deal. And I you know, I just wouldn't bother doing it nowadays because it's just like something that there's no need for me, you know, but all my original training suggested that it was a good thing to do. So you certainly can needle here, but with a small needle, very thin,
Yeah.
and very easy to avoid the artery. And certainly with a thin needle, even if you did, it wouldn't be able to enter the artery, because then if you use a 0.12 needle, the
Yeah.
artery is going to stop it. It's not going to let
Yeah.
it in. So you're going to feel way resistance before, and you're going to go, why is this resistant pulsing? So you'll get it. Um, those are the major things that I would say to look at, besides whatever else the patient has, because you never know what it is that's causing it. But the dogmas is either autonomic nervous system with blood pressure possibility, or hormonal, or mechanical stuckness, like arthritic type. Um, but definitely look at the front as well.
Yeah. And when you're palpating with the scalenes, do you like press towards the clavicle, or do you like kind of? I'm always feel I'm a little bit awkward there or
No,
something. Are
definitely
you
not.
pressing?
Not towards the clavicle, just straight in. So I go stomach 11, 12 area here and above, and so I'm on the edge of the clavicle and then above it. But no, I'm oh, that hurts. Uh, I'm pressing straight in, and towards the clavicle doesn't hurt. Okay, so no, I'm pressing
Yeah,
straight in. No real direction.
yeah.
Because this is not a
And
point. It's not a point that I'm needling, generally speaking. Occasionally you could needle a moxa, and if I do, I'll do it towards the outside, superficial towards the outside.
yeah. And also just on the palpation, you often mention, that you press on the vertebrae, to see if there's any, any pressure pain.
Suggestion. Mhm.
Are you pressing, um, if you're going along are you pressing the kind of, what do they call them, transverse processes? Are you pressing?
I can't answer that, because I think the transverse processes actually go further out. I believe they actually, that's my understanding. I've never done a dissection class, like a anatomy lab on a cadaver. So I don't want, but my understanding is that a transverse process is fairly wide. The edges of it are fairly wide. In fact, they possibly get to the bladder line. So I'll answer your question in the Chinese terms. I'm interested in the Jiaji line primarily, wherever the hell that is. Okay, I'm going to the edge of what feels like the vertebrae, but I don't believe that that's a transverse process. I believe the transverse process might be wider. I'm not sure. And so I'm more interested in what's happening on the side, just on the side of the vertebrae, and looking for seeing if there's anything that feels thicker as well as painful. I'm less interested in the spine itself. The dew points generally, occasionally I will find them, and occasionally I'll even needle them. But generally speaking, from a treatment, certainly from a treatment perspective, I'm more interested in the Watto than the dew
So you're
or
looking
the
for
bladder.
more. Yeah,
Sorry?
you're looking for more like tightness or thing along
Tight,
that line.
tightness, and or sometimes things feel loose, but they're puffy. So tightness, resistance, it's almost like, so sometimes what I'll do is I'll slide my hand along the side of the vertebrae, and then suddenly there's like a big bump. It's almost like that there's like something, stuck on it. That tends to be interesting for me, at least as a treatment point. Okay, so I'm looking for like extra tissue for a tissue that has an accumulation on it along the spine. That's like the most common finding. You find it very commonly around T11, T12. That's really common because it's just, not everyone has it, but it is really common. So you'll know that feeling when you hit it. It's not quite like a ping pong ball. Ping pong ball is like a sacroiliac ligaments. I can describe like a ping pong ball. This is more like like someone took cotton ball and stuffed it in there, and then maybe cemented it a little bit. No, because cotton ball is too pliable. You know,
Yeah.
I mean, Kiko used to say like chewing gum. You know, and says it's because, but I don't chew gum, so I don't know what a chewing gum would feel like. You know, I've never like chewed gum and then stuck it on my finger and, you know, like tried to see what it feels like. So to me, there's just something like extra tissue, a little that's puffy, and sometimes it's hard, sometimes it's tight, sometimes it's not hard or tight, but it's still puffy. And actually it's quite common to have the puffiness without necessarily tightness. It's quite common. So, but I would encourage you, just go along the spine, go, and then you will feel that there are places that are on each side, and they don't have to be at the same vertebrae. You will feel when someone has that extra stuff attached. You know, it feels like there's extra stuff attached to the vertebra.
Yeah. Okay. Great.
Okay.
Thanks.
And I think you can also feel when it feels empty and hollow, and where sometimes I'll needle it just to bring chi there.
Mm-hmm. Yeah. So if some vertebrae are too far apart from each other, like there's a big space between two vertebrae, that ideally you want a moxa. If you have the time to do direct moxa on it, and that I would do on the dew line. You know, when a vertebrae is like they're clearly far away from each other, like it's quite significant. So yeah. It won't always be tight, and if a vertebrae is congested together, which is by the way, the extra tissue and the congestion of the vertebrae being very close don't always come together. They're not necessarily associated with each other. And you can have vertebrae that feel, because then it's more like you're feeling you're touching the bone. Okay, and you think, wow, this bone and this bone have no space between them. That's a place to needle. If a bone and the next bone feel too far apart, that's a place to moxa in between. And the tightness, and again, it can feel hollow. It doesn't always feel tight. That's on the side, and it's like that extra tissue feeling. And either way, whether it's tight or whether it's hollow, it will feel puffy.
And you see that all the time with scoliosis. It'll be tight on one side and hollow on the other side of the same vertebrae.
Yeah.
Because that's what's happening, is the tightness is pulling the spine to the side.
Yeah.
And the other side is not strong enough to resist.
Yeah.
Scoliosis is actually very easy to treat, I think.
Oh, you should, Camille, you have a book to write now.
No, I pretty much just told you the treatment. There's no book.
Needle the vertebrae.
That's it.
Well,
you said more than I did, Avi.
Well, I am sure you can figure out a book.
Yeah, well, okay, that's why I'm preparing for a new life, is there'll be research and books. Anyway, let's move on from that.
No need for research, just need for the money. Sorry. Anyway, moving on. Mary Jo, did you have another question?
Yeah, I had somebody that had high prolactin and developed a little tumor. It's a different person now, around the occiput as well. I think from what I read, I think it comes from the pituitary gland.
The posterior, I believe it's controlled by the posterior pituitary. Now, if they have high prolactin, meaning that they produce milk or something? Or am I on the wrong hormone?
No, I don't, not milk, I think, but she just described that there was a little tumor and that she had tested high for this prolactin, and
the tumor is in the occiput?
The tumor was in the occiput, seemingly, I'm not too sure exactly where, but it was kind of related to the pituitary gland.
Okay. Well, it's
But I
certainly,
mean, it wasn't cancerous or anything. I think they
yeah,
kind
I
of dealt
understand.
with it.
Yeah, it definitely shows the connection between the occiput and the hormonal system. She's
Yeah.
kind of like decided that she's going to illustrate the textbook for you. So, um, what I would do, because it's pituitary, um, so okay, so so you want to treat hormones. I believe I think prolactin and antidiuretic hormone, I think those two come from the posterior pituitary as opposed to the anterior pituitary, but it doesn't necessarily mean anything, because it's not like I have different points to treat. Um, so the point for the pituitary specifically is small intestine 3. Okay? So there is some clear understanding that this line of the small intestine and the dew line at the top of the head, and therefore what's underneath it, are related. You see it in the point names. Around DU20, you have a before and after the vertex. DU19 and DU21 are called before and after. Jian and Ho Ding. And you have the exact same thing with small intestine 3 and small intestine 2. The small intestine 2 is called before the ravine. No, Ho Xi is after the ravine ends. Then it's Jiangu, before the valley and after the ravine. And those are the only befores and afters that exist in the body, as far as I know. So there's a clear mirror here. And I don't know if that's why they decided that small intestine 3 is the opening point for the dew, or I don't know what it is, but there's a clear correlation. And you see the tongue people use small intestine 4 for back pain, low back pain. They sort of look at it as Taiyang for Taiyang. So that's one. UB62 is another hormonal point.
60, I did 66.
66, sorry.
Oh yeah, I did that one actually.
Okay, so small intestine 3 and UB66, which are basically anatomically are mirrors of each other. One is on the leg and one is on the hand. Then anything to do with accumulations in the body, I look at liver 8. Liver 8 is the point when you have extra tissue, whether it's fibroid or blah blah, whatever. Some of the reflexes that you can use, and possibly you can use them after you've resolved them as treatments, are small intestine 3. Small intestine 13. The inner border of the scapula, and bladder 2. Okay, these can be reflexes, just like the occiput can be a reflex of the hormonal system, and they can also be treatment areas for the hormonal system. So I would use them first to find how effective your treatment in general is, whatever the liver 8, the small intestine 3, the UB66, whatever else you're doing, according to medical history, abdomen, blah, 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 blah. Check against bladder 2, check against small intestine 3, check against the abdomen, decide what you're doing. Then when they're clear, actually you can test them before. How much does UB2 change the rest of the abdomen? Oh, wow, it really changes the abdomen. Okay, probably a good point. How much does small intestine 13 change the abdomen? So that's one of the first things you do, just check. Don't needle them yet. Then release them if there was any pressure point with everything else that you're doing. So take them as reflexes first, then use them as treatment points if you want. But I would, the three things that come up for me are small intestine 3, UB66, and liver
8. Yeah, she had chronic urticaria actually, and acne as well. She took a lot of antibiotics.
So I would check, So I would check the liver, because lots of antibiotics can affect the liver. And I would treat the liver. I'd also look at kidney 7, large intestine 15 combination as a skin option, and I would check the immune point as an option because of all these antibiotics. I would, and then the question is what happened if something happened in the gut. So, is her small intestine intact? Is her digestive system intact? So small intestine, I would check by pushing my whole palm on around the navel. So possibly Ren 6 might show, or Ren 9 might show separately as pressure pain, like normal. Like I press 3 fingers in as opposed to the whole palm. So I would, and as it happens, you're treating small intestine 3 anyway, so you're kind of addressing the small intestine, but there may be more to be done if, all these antibiotics conceivably killed her own microflora, blah, 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 that there may be more stuff to look into in terms of digestion, just historically speaking.
Yeah. She didn't really have a whole lot actually on the abdomen. She had Rin 12. And actually what I noticed, Avi, as well in quite a few patients, the inguinal ligament, a lot of people seem to have just pain just at the very top, at the kind of like the, it's not really,
or
a little
lateral.
bit higher. Yeah, just at the, nearly at gallbladder 26, maybe a tiny bit lower than, a lot of people seem to have a lot of pain there, but then no pain as you go down the ligament. It's still,
I haven't encountered that, quite honestly, so much. I'd have to think about that. I suspect, well, it triggers a whole bunch of options. Well, Monica has these patterns where that area is considered, and since I'm not a good Monica person, I can't tell you what they are. I believe one of them is a cross liver syndrome, and one of them is a Chow indication, but I don't want to guarantee that. I'll look it up and I'll let you know.
I think he has one, the dye where you have kind of pressure pain along
both sides. Okay.
Along the center, kind of. That's nearly. It's quite high. I was just thinking it was a little bit too high, nearly for the ligament.
Yeah. I would say if you're getting towards gallbladder 26, if you're getting, like pretty much where the ASIS is, you're not on the inguinal ligament.
Yes.
Okay?
Yeah.
So what that triggers for me is because that's not a finding I have a huge amount of. I also don't check it a huge amount, but maybe now I'll go, it's worth checking. I am going to, it could. I'm not sure if, I think the psoas can go just about to the edge there. So the thing is, I'm anticipating that given the changes that the world has been going through in the last 6 months, abdominal findings are going to change. Things that we didn't see before or were minor before will become major, and things that were like your bread and butter findings will probably disappear, and new findings will become the big deal. So it's possible that you're seeing the next wave of findings, and then one would have to sort of say what's going on. And one theoretical explanation, I mean, this is all theory and just intellectual masturbation at this point, because I haven't touched it, so I can't correlate it at all. And you also need a certain number before you start saying, oh, okay, I wonder if that's what it is. But it could be that, well, first of all, the psoas is since it's on the edge of the psoas is a muscle of survival. It's your coil, so core. Another one is that your hip girdle is a guard. Okay, so it's you can say that it's your root, even though your root should be your feet. And it'll be interesting to see what people's feet are going to start looking like in 2 years. But there is a possibility that there is that there's a rotation of the pelvis or something, that then the muscles can't adjust, and that this rotation is coming from a number of different possibilities. They could be an emotional attitude of fear, of isolation, all these things. It could also be from people's postures being so different because we use our bodies differently now. people are more at home, working at home, sitting at home, not interacting. So even if you're doing the same work, you're sitting on a computer and, I don't know, researching whatever, doing market research, I don't know, whatever it is that people do at work. And now they're doing it at home. Well, when they were in an office, they were interacting with other people. They were getting, I mean, their posture is bound to be different if they're working at home. I just don't know enough, and I quite honestly, I don't know. And every region is different. I mean, we're so early in this. We don't know enough about how people's habits are, but I'm assuming people are going out less. They're doing. I mean, I know that people are going out to nature because they're limiting how many. You know, like in the parks, they're limiting how many people can park and stuff. So they're definitely going out, but maybe they might be going out like once a week, and then the rest of the time they're pretty much closed and not interact. They're not getting in and out of chairs as much as they used to. So it's possible that the posture is changing, and therefore the iliac bone position is changing. They're also, for example, they're not going to the gym or to the yoga classes and things like that, right? So they're getting less use of their legs and of the body than they used to. So it'd be interesting to see. We'll try and remember this and talk about it in a year and see. Oh yeah, Mary Jo had her finger on that finding. That's the big one. If it is related to emotional or even postural attitudes to do with COVID, I would look at either at kidney 6 and or a combination of kidney 6 with Vita 62 as a chow adjustment, and if not, I would look at stomach 41 or the stomach chi line as a possibility for readjusting the ability to stand up, to press down into the world. You know. Okay. I don't have, because otherwise that finding of just next to the ASAS is not a huge one for me, and I don't have great dogmas for it.
Okay, thanks.
You're welcome. Anything else?
Very hot soles of feet. I know the coolness is the kidney, right? But you know, if somebody experiencing a lot of heat in the sole of the feet.
Yeah, it's rare. Well, it does happen, and I've had someone like that actually. I mean, normally you have more like heat goes up.
Yeah.
Feet are cold, but if the feet, I've had someone who's like always burning, and you know, really feels like the feet are burning. I'm trying to recall what I did for her because she claimed it helped. It was like 2 years ago, and I don't fully recall. I do remember that. So I looked at it as the way a few things. First of all, you want to make sure that the inguinal is open. Not the inguinal, the inner thigh is open. Because if there's congestion around liver 12 area, it may create a situation where the blood can't return and it gets hot. The circulation isn't good. I looked at it a little bit like a reverse Jouet syndrome. In Jouet, you'd have the opposite. Everything goes to the head. So I looked at it as that. In the other Jouet point, so I don't necessarily want to needle the bottom of the feet for that, but I needle the stomach chi. And I released the neck. I remember that much on it. But yeah, there is a definite lack of coordination of circulation. So I would check the diaphragm. I would check the neck. I would check the neck, the diaphragm, and the inner thigh. So your pelvic diaphragm, so to speak, to make sure that everything is coordinated well. And one way you can try and address all three of them and open them is through side gallbladder 27, Wushu, opening up the glute medius, and that has an effect on all three diaphragms and all the way to the feet. So that's an option.
Yeah. Yeah, she did have actually a lot of stomach chi bumps.
Oh, okay, yeah. So I would look at treating those. And sometimes if the stomach chi bumps are painful, then you have to look at trying to treat something else. So your first recourse for that would be to treat REN 12.
Okay.
Okay. So REN 12 has a good effect on the stomach channel, on especially below the knee.
Okay. Yes.
So this is someone where if they have a bunch of stomach chi, bumps,
Yes.
and
Yeah.
she has that syndrome, what I would do is don't let yourself get away with just one bump. Just do 3 or even 4 of the bump.
Yeah. Yeah.
That's the kind of person that's worth doing a few of them.
Yes. Yeah.
Seeing what happens. And you may end up needling liver 12, for example.
Yeah.
Towards the torso, to release more circulation.
Okay. Yeah. Great. Thank you.
You're welcome. Camille, anything?
She's
gone for coffee.
Yeah.
Sorry, it took me a moment to unmute.
Okay.
No, I'm good today. Thank you.
All right. All right. Anything else?
Anything else, Mary Jo?
Just one last thing, maybe, Avi, on
Yes.
fluid retention.
Mm-hmm.
Spleen 7 and 3, isn't it? And usually, but I was just wondering, was if you wanted to do spleen 7 and spleen 2 has a lot of pressure pain as well, would you do all, like, would you do 5? Is it too many to do?
Yeah, definitely
3?
too many. So this is what I would do. Okay. So depending on how flexible you feel and how, everyone's different, and how many findings you have in the abdomen and how well you're solving it and what else is going on. So the first thing is I will do is I would start with spleen 7. Find the place where you're pressing and there's a dent and it's puffy, and needle and do moxa, and then check spleen 2 again at that point. If spleen 2 now is just fine, not every fire point pain requires metal and water. Okay, it's just, that is the dogma for it, but sometimes it will get better with something else. So spleen 7 is your major point for the edema. Okay, out of the 3, 7, 11, do not let go of 7. If you let go of 3, you let go of 11, okay, no big deal. Now 11 is like a non-point. It's no big deal. You can add it on. So now the question is, so now you've done your spleen 7. Now let's assume the only finding you have is spleen 2. That's the only thing you're considering. But assuming you have 5 or 6 other findings, or let's say you do, you're going to do the exact same thing that I'm talking about around spleen 2. You're going to do with all the findings. Do spleen 7, see how good the findings are by pressure. Then press spleen 9 alone, see how good it does. Then press spleen 5, see how good it does. Then, so you have an idea. Now you may end up saying spleen 5 and spleen 9 are totally useless. So you let go. You may come to a point where you may figure out that spleen 7 is useless, or spleen 3 is useless, whatever it is. So you have, let's say you found that all spleen 3, spleen 7, spleen 5, and spleen 9 are all useful. They're all equally useful by pressure. On spleen 2 and all the abdominal findings, they're equally good. I mean, that's like your worst nightmare kind of thing, So what you do, I mean, it's actually good because it means maybe you can just use one of them and it does the whole job. So you start with spleen 7 because the symptom is edema, and that's your trump card for edema. That's your most important point for edema. You start, you needle, you moxa. Now you check your spleen 2. Still something in spleen 2, fine. Can I get away? You can still do spleen 5 and 9 because spleen 7 is not a 5-element point. What you really shouldn't do is you should not do spleen 3, 5, and 9. But 5, 7, and 9 is okay. And 11 you can always add. Not a big deal. You can always add, especially for larger type people, because it's like a shuttle point. It moves the stimulation from the leg further up. It jump starts it. Okay, so not jump starts it, but the opposite of jump starting, whatever it would be. So the big question here is, what are you going to do? Are you going to do spleen 3, spleen 5 and 9? Spleen 3 and 9 are okay. I've done spleen 3 and 9 often together. Not a big deal. Even though it's supposed to be huge contradiction, earth and water, blah, blah, seems to work. But once you're starting to talk about spleen 3, 5, and 9, all 3 of them together, regardless of spleen 7 is not coming into play here, that's too much in all likelihood. So you're going to have to choose. Do you want, I would say if you feel that spleen 3 is super important for this person, it really is the one point that addresses something nothing else does, go with spleen 3 and 9, because that's a combination that I know works. They're congenial with each other.
Yeah.
But 5 and 3, I can't say. I don't have the experience of doing 5 and 3. And certainly 5, 9, and 3 would. So you just manipulate your way through. But you know that you want 7, and you see what you can get away with 7 only.
Yeah.
And then you say, oh, if 7 took away the fire point pain, and the edema is the most important thing here, and all other things being equal in terms of spleen 3's ability to influence the abdomen, spleen 5 and 9's ability to influence the abdomen, they're doing the same, I would go with 3. Because the thing that triggered you to want to do 5 and 9 is gone. So sometimes fire point can go away with other points that are not metal and water. It's just a suggestion that metal and water would be a useful thing here. Okay, and then you check with the rest of the abdomen, like you say, and by the way, the fire point where I take it most seriously is in the kidney channel and the pericardium channel. That's when I really, with the lung channel, it's almost a given, because it's very rare that I'm going to think of other points besides lung 5 and lung 8. I don't have a lot of other points that I use. But with pericardium and kidney, the fire point, the pericardium 8 or the kidney 2, pretty much dictates. But I've had cases, I will say, I've had a few cases where kidney 7, 10 wasn't it, and kidney 9 was a much better point for the kidney 2, let alone the rest of the abdomen. So it's a direction, it's a suggestion, metal water. And then I have to tailor it to the patient. And in a case like you're suggesting, where I start having contradictions, I have to, otherwise I just go, okay, spleen 5, spleen 9, oh, abdomen looks good, everything's fine. I don't think about it. But in a case like you're saying, where there's edema, and I have contradictory points that are called for by my dogmas, spleen 3, spleen 7, I have to make choices. So and every time you make choices like that, you just have to keep evaluating. And accept that the next time they come in, what you wrote down worked may not be the right combination for them next week. That really does happen. It seemed great one week, and there are some people that I've actually had to oscillate between the different point combinations, because one will work one week, another one will work another week. I'd have to keep it's kind of frustrating, so much more work each week. But that does happen. It's pretty rare, but it does happen. That you have to keep changing.
Yes, lovely. Thank you.
Okay. You had something else, Mary Jo?
No, I don't think I had anything else today, have we?
Okay. You just had
no,
the
I think Yeah.
Better look like maybe I have something else.
I think that's probably enough for today anyway.
All right. So enjoy the week. I will be here next Monday. I know it's a holiday here, but you know, no big deal. I'm still here. And yeah, that's pretty much it.
Yes,
So,
thank you, Abby.